Unfortunately, high blood pressure very often is very silent. These days we know that we must measure our blood pressure. We should know the blood pressure like we must know the size of our collar or the size of our shoe. But then it is silent. That's the reason it's also called as a silent killer. You don't know that it's high. There's no symptoms unless some of the people get some symptoms, but everybody doesn't get those symptoms.
And joining me today is one of India's most respected voices in cardiovascular medicine, Padma Shri Dr. Upendra Kaul, Chairman at Batra Heart Center, Batra Hospital and Medical Research Center.
Well, hypertension is a mammoth problem throughout the world, and it is unfortunately gallopingly increasing. Currently it is believed, if you look at the data, that about 1.3 to 1.4 billion people in the world have high blood pressure. That means the complete population of India is about 1.3 billion. So in the world, there are about 1.3 billion hypertensives. You see, if we have, as per the Indian data of ICMR, the prevalence of hypertension is around 33%. Now, 11% of the people are diabetics. Diabetes and hypertension, when they are together, it's also called a deadly duo. And similarly, you can have dyslipidemia because you are diabetic. Urbanization, people started moving from rural environment to urban environment because of a number of reasons, getting jobs, studies, and many other things. After that, what happened is that the lifestyles changed, the diet changed. No longer are we taking those coarse grains and other things. We start taking these processed foods, these pre-prepared, and this culture has come. Very few people take 3 to 4 servings of fruits and vegetables in a day. So lifestyle and the diet has been a very, very important part.
Hello and welcome to Blood Pressure Unmasked, a special podcast series by Voice of Healthcare, created to drive greater awareness around hypertension and supported by AstraZeneca. In this episode, we take a closer look at the complete clinical journey of hypertension, from understanding what high blood pressure really means to the scale of growing burden it places on cardiovascular health, and the often overlooked mechanism that may contribute to uncontrolled blood pressure in a significant number of patients. Now, we will explore why hypertension continues to remain one of the most pressing cardiovascular challenges of our time and what more needs to be understood in managing it effectively. And joining me today is one of India's most respected voices in cardiovascular medicine, Padma Shri Dr. Upendra Kaul, Chairman at Batra Heart Center, Batra Hospital and Medical Research Center. Dr. Kaul, it is a pleasure to have you with us. Thank you so much for joining.
Thank you very much, Simiran.
Thank you, sir. Sir, to begin our conversation and to shed light on basically hypertension, how do we define hypertension in today's time, and why have the major guidelines shifted their threshold over the recent years, and why does this mean and what does this mean clinically?
Well, I think it's a very important question. First of all, I would like to remind the people, including you, that there was a time in early 19th century that people used to think they knew what is blood pressure. They used to think higher the blood pressure, the better it is, because it will perfuse the organs very well. And it was only when one of the US presidents, Roosevelt, I think, he died of a stroke and his blood pressure at that time was 220. Then people started to say, no, my God, high pressure is not good. And now today we know the pressure. What is blood pressure is what is high blood pressure means any pressure beyond which the cardiovascular system starts getting stressed in the form of getting events like heart failure, heart attacks, kidney damage, eye damage. So that is the pressure, and usually, we say that blood pressure should be kept less than 130 by 80. One of the very important US studies, Sprint study, suggested that lower the better, 120 by 80 is even better. But that study was done in a very, atmosphere which was not usual practical. You sit down for half an hour in a room away and then no coffee before that, no talk before that, and then measure the pressure. So in all practical purposes, we today say that pressure should be less than 130 by 80. Closer it is to 120 by 80, the better it is. But it should be 120 by 80 naturally. By giving medicines, bringing it to 128 is good, but one doesn't aim with medicines at 120 by 80, because that might mean taking two, three, four tablets, and which for compliance purposes and side effects may be high. So we also Europeans say that anything more than 140 by 85 is hypertension, but at the same time they say it should be less than 130 by 80. So I would say that our blood pressure should be less than 130 by 80, but lower the better, es- especially in some high risk situations like people with heart attacks, people with already having a renal damage, creatinine elevation, and all that. It should be lower the better, up to an extent, not going so low that perfusion becomes very low. So that's what is hypertension.
Thank you so much, sir, for explaining us that. And actually, the ideal blood pressure, and like you said, it should be ideally less than 130 by 80. I think this is a number which our audience must keep in their mind, and do their lifestyle changes and whatever is required to keep their blood pressure normal. So, as we move on to the burden of disease, could you explain us the normal physiology of blood pressure regulation and what keeps blood pressure in balance and what which system are most clinically relevant?
Well, it again is a seemingly simple question, but a complex interplay of many systems. Like blood pressure, otherwise, is a product of stroke volume. When the heart contracts, it brings out a particular volume with every contraction, that is the stroke volume. And when you multiply it with peripheral resistance, because the blood vessels in the periphery produce a resistance to its flow. So it's a product of that. So it is regulated by many things. It is regulated by sympathetic nervous system, which increases the heart rate, which increases the blood pressure. It's also regulated by parasympathetic nervous system and the associated systems, in which, uh, if you stimulate parasympathetic nervous system, the heart rate starts becoming lower. So it's a very delicate balance between sympathetic system, the parasympathetic system, and also the endocrine system, like the renin system. Whenever the pressure in the body falls down or the volume becomes low for any reason, that is the blood volume or the water volume in the blood in your vessels comes down, what it does, it starts stimulating the renin angiotensin system, and there's a product called angiotensin 1, which gets converted into angiotensin 2, which is a potent vasoconstrictor. That means it constricts the vessels, and as a result of which, you know, constriction occurs, and kidneys or the adrenals produce, aldosterone. And aldosterone starts retaining sodium and water, and along with that some potassium into the blood. It excretes potassium, retains sodium, and that's how it maintains the what is called as the homeostasis to bring back the volume to normal. So this is a system, endocrinology, sympathetic nervous system, the parasympathetic nervous system, and all the endocrines coming together. And also there's a central nervous system effect on this, that also. Then there are some baroreceptors which also see that if the pressure is high, they get stimulated and they try to reduce the heart rate so that, the stroke volume uh, remains the same, but heart rate comes down. So in a minute's time, every minute when it beats, it will come lower. So that's how it is maintained, and it is very complex. And nature has given us all these systems so that the blood pressure remains nearly normal, so that we live longer, we live without disease for many, many years. Otherwise, if it was imbalance from young ages, you get into problems early: heart attacks, strokes, kidney failure. And there is a small minority of people who get this, and that is what leads to several problems, and they have to be visiting hospitals so at different stages with different problems. Unfortunately, high blood pressure very often is very silent. These days, we know that we must measure our blood pressure. We should know the Our blood pressure, like we must know the size of our collar or the size of our shoe, but then it is silent. That's the reason he's also called as a silent killer. You don't know that it's high. There's no symptoms unless some of the people get some symptoms, but everybody doesn't get those symptoms. So that is very important to understand, that don't wait for the symptoms to occur. Don't feel when the patient is going to get headache, when the patient is going to get dizzy, when the patient is going to get sweating and feeling very uneasy, you measure the pressure. No, it can be silent. So you should be knowing your blood pressure in all the states.
So thank you so much, sir. And like you mentioned that it is yet a very complex system, and there's a lot of mechanism involved in this. So moving ahead, and understanding this in much deeply, how serious is the global burden of hypertension today currently, and in terms of prevalence of cardiovascular events, hospitalization, and real world blood pressure control rates in your experience, if you could shed some light on this.
Well, hypertension is a mammoth problem throughout the world, and it is unfortunately gallopingly increasing. If it was, currently it is believed, if you look at the data, that about 1.3 to 1.4 billion people in the world have high blood pressure. That means the population, complete population of India, is about 1.3 billion. So in the world, there are about 1.3 billion hypertensives, and it leads to uh, it is one of the most important cardiovascular problems in our day-to-day life, hypertension, because it leads to uncontrolled hypertension, leads to several problems. It leads to cardiovascular events, it leads to myocardial infarctions, strokes, renal damage, kidney fibrosis. It can lead to retinal problems. It can lead to blindness. It can lead to peripheral vascular disease because of constriction, and often hypertension is combined with many other problems. It doesn't exist in isolation. You see, if we have, as per the Indian data of ICMR, the prevalence of hypertension is around 33%, 32 to 33%. Now, 11% of the people are diabetics. Now, diabetes and hypertension, when they're together, it's also called a deadly duo. You know, both together play havoc. And similarly, you can have dyslipidemia because you are diabetic. So your cholesterol levels become high, your triglyceride levels become high. So the force with which the blood is hitting against the wall becomes much higher, and this cholesterol high gets into the vessels. It forms plaques, it produces atherosclerosis, it produces all the problems of atherosclerosis. So that's how, you know, it gets combined. And then obesity is another thing. Obese people very often have hypertension. Obese people also have diabetes much more commonly as compared to, not non-obese people. Then they also have obstructive sleep apnea. They, have snoring during sleep, during which the oxygen content comes down, and you start off, as if, if you've heard somebody snoring, that breathing just stops in between. The person is drowsy during the day, and you can diagnose OSA by a sleep study. And then, if you treat that by giving them, CPAP machines or something, and many people use it at night. They don't tell you that what they're using it, but it's a very useful tool. So all these problems can exist together, and that's how. And hypertension is one of the central things in all this. Hypertension is one of the driving things, along with other metabolic problems. And you also know that India is the capital of diabetes. Also, as I already told you, around 11 to 12% diabetics in our population, and about 15% have pre-diabetes. That means uh, they are not frank diabetics, but their HbA1c is between 5.9 and 6.4. And pre-diabetics are also prone to Same complications, vascular complications of diabetes, although their sugars may not require, uh, you know, uh, lowering down by the potent agents, but that is also a combination. So it's a problem which exists in large number of patients. I already told you it's an enormous mammoth problem all over the world, and controlling the blood pressure. If you even after knowing the blood pressure is controlled, only of all the hypertensive, I don't think more than 50% are coming for treatment. And out of those 50% who are coming for treatment, not more than 30% of those are really controlled to what we are saying 130 by 80. So you see that blood pressure control, perfect blood pressure control, is not easy, and it is not seen in large number of people. But at the same time, I'd like to say that even 10 millimeters reduction in blood pressure is helpful. It's going to reduce cardiovascular events by 20%, heart failure by about 25 to 27%, strokes by about 30%. So every millimeter reduced always pays dividends. Of course, getting to the target is the best, but even if target is not being reached, you are helping the person, you are helping the patient. And then every time you don't have to use drugs only, there is something called non-drug treatment of hypertension. Diet, less salt, take only 3 to 4 grams of salt per day, do regular exercise, you know, overweight people reduce weight, and some mental relaxation, yoga, and other things, they all help towards reducing the blood pressure. But in spite of that, a large number are going to require medicines. But these measures make sure that you require less number of medicines, less doses. So they all are a part of the complete holistic management of high blood pressure.
Very rightly highlighted, sir, and stressed upon that India is already facing a large number of citizens having high blood pressure, diabetic, pre-diabetic, or at the verge of being diabetes. So I think there are some measures with doses or without doses which you mentioned. We can take care of that. We can do some lifestyle changes. We can go to doctors for the treatment. We can take regular medicines. Be aware of our health. I think that way every person can take care of their health very well, and if controlled, if taken care, yes, diabetes, blood pressure is something which can be managed. And India is slowly moving towards the lifestyle diseases as compared to the earlier times where the infectious disease were at a bigger
Absolutely.
pace. So I think now we need to work on our lifestyle, our habits. That's how we can improve our country's health only.
See, the last 100 years, things
So
have changed.
definitely.
100 years ago, May 1920s, which was infectious diseases, which were the predominant thing, and the mortality because of cardiovascular diseases used to be less than 5%.
Yes, sir.
Today, the mortality because of cardiovascular disease is about 27%.
Hmm.
It has all come over period of every 10 years things kept on changing. Urbanization, people started moving from rural environment to urban environment because of a number of reasons, getting jobs, studies, and many other things. And after that, what happened is that the lifestyles changed, the diet changed. No longer are we taking those coarse grains and other things. We start taking these processed foods, and these pre-prepared McDonald's, and this culture has come, pizzas and other things which are full of salt, and
Yes.
they appear good to the palate. They're also economical. You don't have to cook in your kitchen, but then it's very good. Very few people take 3 to 4 servings of fruits and vegetables in a day. We always talk about it, but then we don't do that. So lifestyle and the diet has been a very, very important part in increasing the prevalence of hypertension. And many people these days require 2 drugs, 3 drugs. And I know people who are taking 3 drugs, yet their blood pressure is more than 150 millimeters of mercury. Sometimes you say maybe the gentleman or lady is not taking the medicines regularly, and there have been studies on this. They have done, urine examinations to see compliance, because if you're taking medicines, then urine is going to show that you are taking medicine. May not the same dose, but you are taking medicine. But in spite of urine showing that compliance was there, uncontrolled hypertension is still 50% of people do not have blood pressure to the target levels. So that brings us, a very important area. What do you do? Is it their fault? It's not their fault. So there is something wrong, and that something wrong is common. It's not very uncommon. It's not rare. And as we were talking about this aldosterone thing, and there is always, if the body produces more aldosterone as compared to renin, there's a ratio called aldosterone to renin ratio, which is these days available from any good biochemistry panel. You can ask for a aldosterone renin ratio, and if it is more than 30 or so, that means aldosterone is too much and renin is low. This is one of the very important mechanisms of resistant hypertension. Resistant hypertension, we say, if you're taking three drugs and one of them is also a diuretic, and still your blood pressure is high, it's resistant hypertension. And one of the important reasons is this increased aldosterone to renin ratio, which is a common test these days, nothing an esoteric test. Yeah.
So, as we are talking about this and how the things which are associated with hypertension, there is also a term which is called resistant hypertension. So, how is it defined clinically, and what burden does it carry in terms of prognosis and downstream complications?
Well, resistant hypertension means usually if you're sure that the person is taking the drugs which have been prescribed and three drugs, very often people say that one of those drugs should be diuretic, a water pill. And if the pressure is still not coming under control, you call it resistant hypertension. Resistant hypertension sometimes, once again, can be totally asymptomatic. But then, resistant hypertension is going to be associated with much more morbidity and mortality. It's one of the important causes of cardiovascular events, strokes, heart failure. Heart failure is a very important complication of high blood pressure. In fact, one of the most important causes of heart failure is uncontrolled blood pressure. And if you get a myocardial infarction, your heart muscle is already weak. At the same time, your pressures are high. That weak heart has to pump against a very high pressure. It's becomes even weaker at that time, and then you get fluid accumulation in your lungs, and you actually get what is called as acute decompensated heart failure, which has a high mortality. Heart failure has a mortality of 50% in 5 years. It's a very serious thing. And hypertension is one of the most important things, and resistant hypertension actually is one of the very important causes of heart failure.
So we also discussed about the cases and condition where in a situation patient is not taking care, or they're not taking medicines, they're not following what doctors has prescribed to them, and there comes the non-adherence, and that is what we always blame for the uncontrolled blood pressure. But what does the evidence tell us about the patients who are genuinely adhering to the guidelines, to the prescription which the doctor has explained us, and still cannot reach the target?
Yeah, that's what I was telling you, that adherence is an important thing. Compliance with the drugs is an important thing.
Yes,
But
sir.
it's not that every person with uncontrolled hypertension is non-adherent. There are studies showing that 50% of them are controlling the blood pressure. And as I told you, there are ways of proving it by doing the urine test casually and just seeing that, yes, he is taking drugs, because those drugs get excreted in urine. So, in spite of that, uh, getting a resistant hypertension, drug resistant hypertension, is not a rare thing. It is frequently seen. And these are the people, these are the patients who get into the complications. So
Yes.
one needs to get to the basis of this resistant hypertension. Why is the person getting resistant hypertension? it has to, besides the compliance thing. And as I told you, that excess aldosterone production is one of the very important causes of it. And that is the reason we are more and more stressing about the relationship of this ratio with uncontrolled hypertension, the aldosterone renin ratio. Estimate both, take a ratio, and if it is normally it should be between 10 to 25, 30. If it is beyond 30, that means aldosterone production is far excessive as compared to the renin, because they have a control mechanism. Normally, if aldosterone increases, the renin, you know, suppresses it. It does not allow it to produce more aldosterone. But once the organ becomes berserk, it starts going on, it becomes autonomous kind of a thing, goes on producing it. So that has to be found, and then we are going to have methods of checking it. There have been some medicines traditionally in resistant hypertension when used to start a group of medicines called aldosterone antagonists. Spironolactone was one. It has some side effects and the thing, but this has been one of the very valuable uh, adjuncts in the treatment of people where the hypertension is not coming under control with the standard drugs. Like standard drugs, when we say is telmisartan, beta blocker, and a calcium blocker. These three combinations usually control pressure in large number of people. But if it is not coming under control and you're requiring to start aldosterone antagonist, that is real resistant hypertension. You're targeting actually, even if when we didn't know about this aldosterone renin ratio, aldosterone antagonist used to be added. And now that we know about this ratio, we're coming into a new era of therapies which are going to have agents very specifically targeting at this particular thing, and will have much more better tolerated as compared to aldosterone antagonists. No gynecomastia, no other such things. And eplerenone is another agent which also acts, and that does not have gynecomastia. But then there are sort of general agents which affect so many other systems which are unnecessary. If you have to have a very specific blocker of this thing, then we're going to have some agents regarding that.
So, as you're explaining us about the aldosterone, so what does the evidence tells us about the cardiovascular outcomes in aldosterone dysregulation, particularly around atrial fibrillation, coronary artery diseases, heart failure, and stroke as well?
Yeah, excessive aldosterone is associated with many things. It's associated with fibrosis. That means the cellular components of the organs start becoming more fibrous. That means those nuclei die and replaced by fibers. And the organ is not going to be working the same. If the heart starts getting fibrosis, you're going to get cardiomyopathy. Similarly, if you it also acts upon the nervous system. You start getting problems besides strokes. You start getting other complications like Alzheimer's and other at an early stage. Similarly, if it acts upon the other organs like the kidneys, we already told you, fibrous kidney, you start getting problems into the kidney, and your creatinine starts getting out of control, and patients needing a renal replacement therapy like dialysis, which everybody hates. But then, if you go to any nephrology center, you'll see a line of people needing this thing. And hypertension is one of the most common causes of requiring renal replacement therapy or dialysis, especially if it is combined with diabetes, it becomes even much more magnified. So almost all the organs of the body, starting from head to toe, get affected by this excessive aldosterone production.
So, as you're explaining us about this aldosterone dysregulation and in terms of the renal perspective and the damage it does to the kidney. So, what do the outcome data shows on CKD progression and the end stage kidney diseases as well?
Absolutely. That's what I was telling you, that because of this, the nephrons start getting affected. Nephrons start getting, you know, much less in number because they get fibrosed. And as a result of which, the kidney function suffers. The one of the earliest things is you start getting albumin in the urine. Number two, that's the earliest harbinger. If you get uh, protein in the urine, that means that earlier sign of damage has started, and then it progresses rapidly, and then you start getting the creatinine elevation. And as we talk about creatinine elevation, we always talk about EGFR because that's age dependent. A creatinine of 1.4, which may look benign, if you talk about this in a 70-year-old or 80-year-old person, it is very high. Yes, compared to a 20-year-old or 30-year-old person. So the EGFR indicates the damage to the kidneys. And when the EGFR becomes very low, when you call it stage 3 or stage 4 or stage 5 kidney disease, that means in that situation, the renal acute chronic renal failure sets in, what we call as chronic kidney disease. The kidneys start getting shrunken, and then these patients are the persons who start needing renal replacement therapy. Otherwise, they are going to get into complication. The complications of chronic kidney disease, people actually do not die of chronic kidney disease, but they die of vascular events. They start getting strokes, they start getting much more heart attacks. Much before they're going to succumb to kidney disease, they succumb to vascular events. So that's very important. That hypertension is one of the very important causes of affecting the kidney, and kidney can play havoc with the body if it starts failing.
That's So, thank you so much for explaining us this important aspect also. And when we are talking about aldosterone dysregulation, is this prevalent and consequential as well? And why is it still being missed in practice? And if we have to discuss about from the clinician perspective, what should screening look like for a clinician to managing it, and how it is difficult to control for hypertension as well?
Yeah. Today we say that persons who are not getting blood pressure control with 2 or 3 drugs, think about that is issue based upon increased aldosterone, and get the aldosterone level done. And best is that again and again telling you the ratio of aldosterone versus and renin. And if it is aldosterone is too much, too high, that is earliest test to pick up that this is the person who is getting into problem, and there you start targeting the therapy. There you start looking for, sending the patient to a specialist so that it is not just adding fourth drug or fifth drug is not going to be very useful. Just going on increasing the dose of telmisartan or anything is not going to be useful. So these are the patient, and we have other group of drugs also which help this, you know, regulate this. Something like SGLT2 inhibitors like dapagliflozin and empagliflozin, which basically started as treatment for diabetes. But we know today that they are very renoprotective, that they protect the kidneys, they reduce albuminuria, they stabilize the renal function, and they're very useful in heart failure also. One of the very important drugs in the management of heart failure, whether it is reduced ejection fraction or preserved ejection fraction, is SGLT2 inhibitor. So we have the means of tackling this problem. And as I told you, a number of drugs are working in this particular direction, which are going to reduce this aldosterone to creatinine ratio for the benefit of the, complete vital organs of the body, including the heart, including the kidney, including central nervous system. So that is, I think, just knocking at our doors.
So, as we are moving ahead towards the end of this discussion, before we close it, what would be that single important message you would like to leave with clinicians managing patients with difficult to control blood pressure, and also to our patients and audience who are dealing with blood pressure?
First of all, you must make sure that the person is adhering to the lifestyle measures. It's very, very important. And lifestyle measures is sometimes equivalent to 1 or 2 drugs. That's very important. Following that, he must see that whatever has been prescribed to him, he's not taking it very casually. He's taking it regularly, properly. And in spite of that, if the problem is there, that means that he needs proper attention, and he should not just self-treat himself by taking the same group of medicine twice a day and thrice a day. No, he should get himself evaluated, and that can be the urine test, aldosterone, renin ratio, ultrasound of the abdomen to see the kidney sizes, and that's how they're investigating. And then once you come to the real cause or the real causes of it, then you start treating it. And then I think uh, trained doctor who handles hypertension, there are hypertension specialists, and some of them have good knowledge of nephrology. They have got a good knowledge of endocrinology. They're very good. And then a team, it is a basically teamwork. Then it's not only that I should be only treating it. I always take help of an endocrinologist or a nephrologist. Well, I'm not able to control his pressure. At the same time, he's having proteinuria, and his creatinine clearance, which was about 40, 50, is going below 30 now. What should I do? So I think it's a holistic management, and it needs the awareness. First of all, the patient has to be aware that he is getting into this problem. And so every hypertensive should have a BP machine at home, and he should check the blood pressure. And whenever in doubt, check it with the other machine. But if he is sure the blood pressure is not getting controlled, he needs to see his physician and then tell him what the problem is. And then the physician has to decide whether he is going to handle it himself or is he going to take help of his colleagues in various departments. But the point is that it should be recognized early so that early management is done so that complications are prevented or caught up in a very early stage where the bad effect, the morbidity from the disease is minimized.
I think so. That's what we aim for. As soon as we can reduce the complication, as soon as the patient reaches to the doctor and the adherence to the prescription and the guidelines shared by our clinician, I think that is what we want and that is what we aim for, so that we can control blood pressure amongst our citizen, and they take charge, they take care of their health, and that too not being ignorant. They have to take it quite seriously. Then only we can prevent such incidences. So
Yeah, you're right. Absolutely.
thank you so much, sir, for the powerful and insightful discussion we just had. So today's conversation took us from the fundamentals of hypertension, the scale of the global and Indian burden as well, and then to an important underlying mechanism that may be driving uncontrolled blood pressure in a significant number of patients. But what stands out clearly is that the hypertension is not always just about numbers on a monitor. It can often be a reflection of deeper biological pathways that demand closer clinical attention. As we continue to strengthen the awareness and improve outcomes in the hypertension care, the need to identify these drivers early becomes more important than ever before. Thank you once again to everyone joining us and sharing your expertise on such with such clarity. Thank you so much, sir.
Thank you. Thank you very much.